Thank you very much for the kind introduction. On behalf of WHO, I would like to thank the organizers for inviting me to give a presentation on new prevention technologies at this conference. And following the talk of Jintia Na, I think it's so important to prevent fathers and mothers becoming HIV infected in the first place and prevent mother-to-child transmission, to prevent children of becoming infected ultimately. I will provide an overview on the rationale for use of antiretrovirals for prevention, present recent data for both prevention of HIV acquisition and transmission, and briefly touch upon the work of WHO in this context. 3 decades into the HIV epidemic, we continue to see 2.6 million new infections annually. For every person starting antiretroviral treatment, 2 people are newly infected with HIV. At the same time, it is increasingly becoming evident that prevention efforts are producing results, and we have seen encouraging declines in HIV prevalence in several countries here in Asia. We need to sustain current, effective, and affordable prevention programs at sufficient intensity and scale, such as condoms and harm reduction programs. But also, we need more effective prevention technologies, new prevention technologies, including an HIV vaccine. 2010 and 2011 were years with exciting results in HIV prevention research. Caprisa-04 was announced in July 2010 using tenofovir gel. IPREX and was announced in November 2010, an oral PrEP study among MSM and transgender women. The FemPrEP study was stopped for futility in April this year. HPTN 052 was already mentioned. The delayed treatment arm was stopped for efficacy. In July, Partners PrEP was announced. The placebo arm was stopped for efficacy. And CDC announced the positive TDF2 results, also at the International AIDS Society conference in Rome. So why the interest in use of antiretrovirals for prevention? We have biological plausibility. Sexual transmission of HIV is predicted by viral load and is rare when a person has less than 1,500 copies of HIV-1 RNA per milliliter. Numerous animal models since 1995 show protection for pre-exposure prophylaxis of antiretrovirals. Antiretroviral post-exposure prophylaxis after accidental needle stick injury reduces the risk of HIV acquisition. Further proof of concept that ART interrupts HIV transmission can be found in efforts to prevent mother-to-child transmission of HIV. Observational studies have demonstrated the potential of antiretroviral therapy for prevention through its significant effect on lowering viral load. What is pre-exposure prophylaxis, or PrEP? It is an HIV prevention strategy that uses antiretroviral agents prior to HIV exposure to prevent HIV acquisition. PrEP for HIV prevention builds on the concept that medications can be used by healthy people to prevent other infections, such as the example of malaria prophylaxis or INH preventive therapy to prevent progression of latent to active TB. The drugs used currently in clinical PrEP trials are tenofovir and a combination of tenofovir and emtricitabine. Both drugs are potent. They have a broad antiretroviral activity. They are active against virus types found both in early and late HIV infection and act early in the life cycle of HIV, blocking initial infection. Both drugs are rapidly active. They are safe and easy to use. The Caprisa-04 study showed that 1% tenofovir gel applied vaginally 12 hours before and 12 hours after sexual intercourse lowers HIV incidence by 39%. HIV incidence in the tenofovir gel arm was 5.6 compared to 9.1 per 100 women years in the placebo gel arm. In high adherers, defined as gel adherence more than 80%, HIV incidence was 54% lower in the tenofovir gel arm. The IPREX study showed that once daily oral tenofovir emtricitabine provided 44% additional protection from HIV among men or transgender women who have sex with men who also received a comprehensive package of HIV prevention services. Although reported pill use was high, drug exposure that was measured objectively was substantially lower. Detectable blood levels strongly correlated with the prophylactic effect, with a relative risk reduction of 95% in those who had unprotected anal intercourse when taking the drug. In April 2011, FHI 360 issued a press release announcing that FemPrep trial of daily oral tenofovir emtricitabine conducted among women at higher risk of HIV exposure was stopped, as it was not likely to demonstrate a significant protective effect by the time of the study's planned conclusion. The reasons are not entirely clear. Possible explanations for lack of efficacy are poor adherence, drug sharing, differential compartmental PK, or just mere chance. The Partners PrEP study showed that both daily tenofovir and daily tenofovir emtricitabine taken before HIV exposure can prevent heterosexual transmission of HIV to women, from women to men, and from men to women. The trial followed serodiscordant couples in which one person had HIV and the other did not. Couples received counseling and free male and female condoms. The uninfected partner took daily tenofovir or tenofovir emtricitabine or a placebo pill. Those who received tenofovir had an average of 62% fewer HIV infections, and those who received the combination 73% fewer HIV infections than those who received placebo. The TDF2 trial in Botswana followed men and women who were randomized to receive tenofovir emtricitabine or placebo. Those